ocular hypertension. Ocular hypertension is labeled when a patient has an IOP constantly more than 21 mmHg, but no optic disc and visual field changes. These patients should be carefully monitored by an ophthalmologist and should be treated as case of POAG in the presence of high risk factors. Glaucoma suspect is defined as an adult having normal open angle on gonioscopy and any one of the following signs in at least one eye: elevated IOP the more than 21 mmHg, suspicious disc changes in the form of asymmetric cup disc ratio, difference greater than 0.2, notching, narrowing of neuroretinal rim or disc hemorrhage, visual fields consistent with glaucomatous changes. Risk factors for development of POAG among individuals with ocular hypertension. High risk for development of POAG reported by ocular hypertension study, European glaucoma prevention studies. IOP consistently greater than 30 mmHg, central corneal thickness less than 550 micrometer, vertical cup disc ratio more than 0.7, increased age, increased pattern standard deviation on Humphrey visual field, disc hemorrhage, splinter hemorrhage over or near the disc. Other reported risk factors: family history of glaucoma or known genetic predisposition, fellow eye of unilateral POAG. Other ocular conditions include suspicious disc appearance, myopia, positive diurnal variation, steroid responder, low optic nerve perfusion pressure. Systemic risk factors include diabetes, sleep apnea, hypertension, cardiovascular disease, hypothyroidism, migraine headache and vasospasm. Treatment: patient with high risk factors should be treated on lines of POAG. The aim should be reduce IOP by 20%. Patient with no risk factors should be annually followed by examination of optic disc perimeter and record of IOP. Treatment is not required till glaucomatous changes are observed. Normal tension glaucoma. Here the intraocular pressure is normal, but there will be visual field defects and disc changes. The IOP is constantly below 21 mmHg. Normal tension glaucoma accounts for 16% of all cases of glaucoma and prevalence above 40 years is 0.2%. Etiopathogenesis. It is believed to result from chronic low vascular perfusion, which makes the optic nerve head susceptible to normal IOP. The view is supported by following assumptions which are more common in NTG than in POAG. These are common in NTG: normal tension glaucoma, Raynaud phenomenon, peripheral vascular spasm on cooling, peripheral vascular spasm, migraine, nocturnal systemic hypotension, overtreated systemic hypertension, reduced blood flow velocity in ophthalmic artery. These are the features seen in normal tension glaucoma. Migraine is important. Raynaud phenomenon, peripheral vascular spasm, nocturnal systemic hypertension, reduced blood flow velocity in ophthalmic artery. Seen in Doppler ultrasonography, transcranial. Clinical feature: intraocular pressure is lower than 21 mmHg. Optic disc changes. Thinning of neuroretinal rim is more significant. Splinter hemorrhage at disc are more frequent. Peripapillary atrophic changes are more prevalent. Visual field defects are essentially similar to POAG but tend to be more deeper, steeper, more localized and closer to fixation point. Characteristic association in the form of ocular vascular abnormalities and systemic vascular and hematological abnormalities may be detected. Differential diagnosis: high pressure glaucoma, POAG. In early stage, POAG may present with normal IOP because of wide diurnal variation. Diurnal variation test usually depicts IOP higher than 21 mmHg at some hours of the day in patients with POAG. Glaucoma with intermittent rise in IOP. Example: glaucomatocyclic crisis. Intermittent angle closure glaucoma. Previous episodes of glaucoma which might have caused optic disc changes, field defects and are now cured. Example: corticosteroid induced glaucoma, uveitic glaucoma, traumatic glaucoma, etc. Non-glaucomatous optic neuropathy, congenital optic disc anomalies such as large optic disc pits or coloboma, which may be mistaken for acquired glaucomatous damage. Careful examination should be help in differentiation. Acquired optic neuropathy such as compressive lesions of optic nerve, shock optic neuropathy, anterior ischemic optic neuropathy, traumatic optic neuropathy, and optic neuropathy due to methyl alcohol poisoning. Treatment. Medical treatment to lower IOP. Betaxolol. It is considered the drug of choice. It increases optic nerve blood flow. Other beta blockers and adrenergic drugs should be better avoided, as these cause nocturnal systemic hypertension and are likely to affect the optic nerve perfusion. Drug with neuroprotective effect, brimonidine, may be preferred. Prostaglandin and latanoprost tend to have greater ocular hypertensive effect in eyes with normal IOP. Trabeculotomy may be considered. Systemic calcium channel blockers may be used in patients with confirmed peripheral vasospasm. Monitoring of systemic blood pressure should be done for 24 hours. If nocturnal dip is detected, it may be necessary to avoid night dose of antihypertensive medication. Primary angle closure glaucoma. It is characterized by opposition of peripheral iris against the trabecular mesh, resulting in obstruction of aqueous outflow by closure of an already narrow angle of anterior chamber. The condition is not associated with any other ocular systemic abnormalities. Epidemiology. There is great ethnic variability in prevalence of PSEG. The ratio of POAG PSEG is seen high in Europeans, African, and Hispanics. Idiopathogens, predisposing risk factors, pathogenesis of rise in IOP, predisposing risk factors, demographic risk factors, age, it presents in 6th and 7th decades of life, gender, female ratio, females occurrence is more, race, Caucasians. PSEG accounts for 6% of all glaucoma present in 6th to 7th decade. It is more common in Southeast Asian, Chinese, Eskimos, etc. It is uncommon in blacks. Anatomical and ocular risk factors: hypermetropic eyes with shallow anterior chamber, short axial length, eyes in which iris length diaphragm is placed anteriorly, eyes with narrow angle of anterior chamber, which may be due to small eyeball, relatively large size of lens, smaller diameter of cornea, or bigger size of ciliary body, or more interior insertion of iris on ciliary body. Plateau iris configuration, heredity. Most cases of PSEG with pupillary block are sporadic in nature. However, predisposing anatomical factors, shallow anterior chamber, narrow angles have been reported as more common in first degree relatives of the patient. Pathogens of rise in intraocular pressure, pupillary block mechanism, plateau iris configuration, phacomorphic mechanism. Pupillary block mechanism is responsible for causation of rise in IOP in most 70% of cases. Precipitation factor, it is predisposed in a predisposed patient with occludable angles with pupillary block causing angle closure is precipitated by following factors. Physiological mydriasis, while reading in dim illumination, watching television, cinema in darkened room during anxiety and emotional stress. Pharmacological mydriasis is well documented to precipitate an attack of angle closure glaucoma. Medication other than topical mydriasis, example phenylephrine, tropicamide, cyclopentolate, homotropin, atropine, reported to participate the attack of attack include tranquilizers, bronchodilators, antidepressant, vasoconstrictors include common nasal decongestion, anti-myotic drugs, and anti-spasmodic. Pharmacology, meiosis induced by drugs like icothiopate, phylocarpine is also reported to precipitate an attack of acute PSC. Valsalva manure is reported to precipitate angle closure in predisposed individual. Mechanism of rise in IOP after mydriasis. The probable sequence is, first of all, due to effect of precipitating factors, there occurs mild dilation of pupil, which increase the amount of opposition between iris and anteriorly placed lens with a considerable pressure against, resulting in relative pupillary block. Consequently, the aqueous collects in the posterior chamber and pushes the peripheral flaccid iris anteriorly, iris bomb, resulting in oppositional angle closure due to iridocorneal contact. Eventually, there occurs rise in IOP, which is transient to begin with, but slowly oppositional angle closure is converted to synechial angle closure due to formation of peripheral anterior synechiae. And an attack of rise in IOP may last long. In some cases, mechanical occlusion of angle by iris is sufficient to block the drainage of aqueous. For this reason, the installation of atropine in an eye with a narrow angle is dangerous, since it may precipitate an attack of rise to IOP. Mechanism of rise in IOP after meiosis. The drugs that constrict pupil are also reported to increase pupillary block. Further, these drugs also contract the ciliary muscles, allowing the genials to relax and lens to move forward. Because of this reason, it is advised to avoid miotics such as pilocarpine in prevention of PSCG in predisposed eyes. Plateau iris configuration and syndrome. The mechanism is responsible for few atypical cases of acute angle closure glaucoma. Acute angle closure glaucoma associated with plateau iris is atypical in patients with a normal central anterior chamber depth, flat iris plane, and minimal pupillary block. It has also been referred in literature as an angle closure glaucoma without pupillary block. The anterior chamber angle is closed by a pushing mechanism because of anterior push and ciliary process displacing the peripheral iris anteriorly. Such a situation is called plateau iris configuration. And iridotomy is sufficient to control IOP in such patients. Iridotomy. Plateau iris syndrome is labeled when acute angle closure glaucoma occurs either spontaneously or after pharmacological dilation in spite of patent iridotomy. Such eyes are treated with miotics and laser peripheral iridoplasty to produce thinning of peripheral lens. Phacomorphic mechanism. Phacomorphic mechanism have now been included. Phacomorphic mechanism have now been included as one of the three basic PSCG mechanisms along with pupillary block, plateau iris. The abnormal lens may contribute to either causing pupillary block or by pushing the peripheral iris forward into angle structures. Though the term phacomorphic glaucoma refers to an acute secondary angle closure glaucoma caused by intumescent or other lens morphological abnormalities, but now UPM and OCT studies have shown that phacomorphic mechanism may be responsible for initiating acute primary angle closure glaucoma in predisposing patients. This also forms the base of lens extraction as a treatment of modality for acute primary angle closure glaucoma. Then mechanism of angle closure glaucoma. A. Relative pupillary block. B. Iris bomb formation. C. Oppositional angle closure, which becomes synechial angle closure. This is iris bomb. Then classification. There are three types of classification: primary angle closure, suspect, primary angle closure, glaucoma, PACS, PAC, and PACG. Estimation of anterior chamber depth by oblique illumination. Normal, shallow. Traditional clinical classification: latent primary angle closure glaucoma, subacute primary angle closure glaucoma, acute primary angle closure glaucoma, chronic primary angle closure glaucoma. Clinical profile and management: primary angle closure, suspect, can be considered analogous to the term latent primary angle glaucoma of clinical classification. Clinical features and diagnostic characters. Symptoms are absent in this stage. Presenting situations. Suspicious clinical signs in routine clinical examination. Fellow eye of the patient presenting with acute attack of PSC. Glaucoma screening program. Suspicious clinical sign noted on ocular exam or eclipse sign, which indicate decreased axial anterior chamber depth, and be elicited by shining a pen light across the anterior chamber from temporal side and noting a shadow on nasal side. Slit lamp biomicroscope. Decreased axial chamber depth, convex shaped iris length diaphragm, close proximity of iris to cornea in periphery. Van Herrick slit lamp grading of angle may be used with fair accuracy. Here the peripheral anterior chamber is compared to adjacent corneal thickness. Presumed angle with is greater at wide open angle. Diagnostic test: IOP measurement, gonioscope, ultrabiomicroscope, anterior segment OCT, optic disc evaluation, visual field analysis, etc. Gonioscopy, IOP, optic disc, visual field. Diagnostic criteria of PSC suspect. Gonioscopy should reveal iridotrabecular contact in greater than 270 degree angle, no peripheral anterior synechiae. IOP should be normal. Optic disc should show no glaucomatous changes. Visual field should be normal. Impression: the angle is at risk. That is the impression. Van Herrick method of slit lamp grading. Grade 0, grade 1, grade 2, grade 3 and grade 4. Management. Provocative test designed to precipitate closure of angle through, though not popular, presently can be performed in patients with PSC suspect. Provocative tests. These tests may be performed in ophthalmologist's office where it can be treated promptly. Prone darkroom test was considered most popular, best physiological provocative test. In this test, baseline IOP is recorded and patient is made to lie prone in darkroom for 1 hour. He must remain awake so that pupil remain dilated. After 1 hour, the IOP is again measured. An increase in IOP of more than 8 mm Hg is considered diagnostic of PSC suspect. Mydriatic provocative test. It is usually not preferred nowadays because of this. This is not physiological. In this test, either a weak mydriatic tropicamide or simultaneously a mydriatic and myotic are used to produce a mid-dilated pupil. A pressure rise of more than 8 mm Hg is considered positive. Inference from provocative test. Positive provocative English indicates angle is capable of spontaneous closure. Negative provocative test: presence of occludable angles and gonioscopy does not rule out possibility of spontaneous closure. So patients should be warned of possible symptoms of acute attack of PSC, primary angle closure. Treatment comprise prophylactic laser iridotomy, periodic follow-up, etc. Primary angle closure suspect. Treatment: if warranted, if more than 270 degree oppositional iridotemporal contact is seen in gonioscopy in fellow eye of all patients present with acute PSC or PSCG in one eye. If untreated, the risk of conversion to PSCG during next 5 years is about 50%. Periodic follow-up is regularly needed. Next condition is next classification: primary angle closure. Eyes with primary angle closure may be considered to comprise following entities: subacute primary angle closure, acute PSC, chronic PSC. Defining criteria for primary angle closure: iridotrabecular contact noted on gonioscope is greater than 270 degree angle. IOP elevated, peripheral anterior synechiae present, optic disc normal, visual field defects normal. Two conditions: iridotrabecular contact is angle is 270 degree greater than 270 degree. IOP is increased and peripheral anterior synechiae is present. Remaining also are normal. Optic disc and visual field defects are normal. Impression: angle is abnormal either in function or structure. Subacute primary angle closure. In these three conditions, subacute primary angle closure, acute primary angle closure, chronic primary angle closure. Let's see about the subacute primary angle closure. Transient rise in IOP 40 to 50 mm Hg. It lasts for few minutes, 1 to 2 hours. Precipitating factors: physiological material while reading in dim illumination, watching television, cinema in dark room during anxiety, and physiological shallowing of anterior chamber after lying in prone position. Pharmacological material following use of pupillary dilating drugs for fundus examination. Symptoms include episode of subacute PSC is marked by experience of unilateral transient blurring of vision. Unilateral transient blurring of vision. Colored halos around light, headache, broache, eye ache on affected sight. Self-termination attack occurs possibly due to physiological meiosis induced by bright light, sleep otherwise. Recurrent attacks of such episodes are not uncommon. Between the recurrent attacks, the eyes are free of symptoms. Signs: usually during examination of eye is white and not congested. However, all signs described above in the definition of primary angle closure should be elicited to table PSC. Diagnosis made from defining criteria of PSC. Differential diagnosis of colored halos in PSC. Colored halos during intermittent attacks of raised IOP in PSC occur due to accumulation of fluid in corneal epithelium and alteration in refractive index of the corneal lamellae. Patient typically gives history of seeing colors distributed as in spectrum of rainbow while watching on a lighted bulb or moon. The colored halos in glaucoma must be differentiated from those found in acute purulent conjunctivitis. And early cataracts changes in conjunctivitis. Halos can be eliminated by irrigating the discharge. The halos of glaucoma and immature cataract may differentiate by Fincham test, in which a stenopic slit is passed across the pupil. During the discharge, glaucomatous halo remain intact, while a halo due to cataract is broken up into segments. Treatment is peripheral laser iridotomy is the treatment. Primary angle closure. Let's see the Emsley-Fincham stenopic slit test demonstrating breaking up of halos due to immature cataract in different segments. This is the halos breaking. Acute primary angle closure. An attack of acute rise in IOP in patients with primary angle closure may occur due to pupillary block causing sudden closure of angle. It usually does not terminate of its own, thus if not treated lasts for many days. It is a sight-threatening emergency. Clinical features: symptoms include pain, nausea, vomiting, prostration are frequently associated with pain, rapid progressive impairment of vision, redness, photopupillary lacrimation. Past history: about 5% of patients give history of typical previous intermittent attacks of subacute angle closure. Signs include lids may be edematous, conjunctivitis chemosed and congested, cornea becomes edematous and insensitive, anterior chamber is shallow, anterior chamber angle of anterior chamber completely closed as seen in gonioscopy, iris may be discolored, pupil is semi-dilated, IOP is markedly elevated, usually between 40 and 70. Optic disc is edematous and hyperemic. Fellow eye shows shallow anterior chamber and occludable angle. Diagnosis of an acute attack of primary angle closure is obviously from clinical features. However, different diagram may have considered from other causes of acute red eye. Acute angle closure sometimes need differentiated from red eye. Other causes of red eye like acute conjunctivitis, iridocyclitis, from acute secondary glaucoma such as phacomercury glaucoma, acute neovascular glaucoma, and glaucomatocyclitic crisis. Management: acute angle closure is serious ocular emergency and needs to be managed aggressively as below. Immediate medical therapy to lower IOP, definitely treatment prophylaxis of fellow eye. Clinical photograph patient with acute congestive glaucoma, note ciliary congestion. Ciliary congestion is noted. Corneal edema and mid-dilated pupil. Long-term glaucoma surveillance and IOP management of both eyes. Immediate medical therapy to lower IOP. Systemic hyperosmotic agents are required initially if IOP is more than 40 mmHg. Intravenous mannitol 1 gram per kg body weight should be preferred in presence of nausea and vomiting. Oral hyperosmotics, example glycerol 1 gram per kg body weight of 50% solution in lemon juice may be given if well tolerated and not contraindicated. Systemic carbonic anhydride inhibitor, example acetozolamide 500 mg stat followed by 250 mg tablet 3 times a day. Topical anti-glaucoma drugs to be instilled immediately include beta blocker 0.5% timolol or 0.5% betaxolol, alpha adrenergic agonist, example brimonidine, prostaglandin analog, latanoprost. Role of meiotic therapy, pilocarpine QAED should be started after 1 hour of commencement of treatment, that is when IOP is lower. As at higher IOP, sphincter is ischemic and unresponsive to pilocarpine. It's a meiotic therapy. So definitive therapy, laser peripheral iridectomy, gonioscopy should be performed as soon as cornea becomes clear. Laser PA should be performed if PAS are seen in less than 270 degree angle. Laser peripheral iridotomy should always be preferred over surgical PA. However, if lasers are not available, surgical PA should be done. Peripheral iridotomy, filtration surgery, trabeculotomy should be performed in cases where IOP is not controlled, with maximum medical therapy following an attack of acute PSC or when gonioscopy reveals PAS greater than 270 degree angle, also when peripheral iridotomy is not effective. Mechanism: filtration surgery provides an alternative to angle for drainage of aqueous from anterior chamber into subconjunctival space. Surgical technique also given. Clear lens extraction by phacoemulsification with intraocular lens implantation has recently been recommended by some workers, especially in presence of phacomorphic etiology. Prophylactic treatment in normal fellow eye. Prophylactic laser iridotomy, preferably or surgical peripheral iridotomy, should be performed on fellow asymptomatic eye as early as possible, as chances of acute attack are 50% in such cases. Long-term glaucoma surveillance and IOP management in both eyes. Eyes treated with PI, peripheral iridotomy, both affected and fellow eye may develop PSCG at any time, so it should be treated as and when required. Filtration surgery may fail any time during the course and hence need to be repeated with antimetabolites. Sequel of acute PAC. Post-surgical acute PAC, this refers to clinical status of eye after laser peripheral iridotomy. It may occur in two clinical settings: with normalized IOP after successful laser PA, usually quiescence after some time, or without marks of an acute attack, Vox triad, or with raised IOP after unsuccessful laser PA, which needs to be treated with trabeculotomy operation. Spontaneous angle responding angle reopening may occur very rarely in some cases, and attack of acute PSC may subside itself without treatment. Ciliary body shunt, it refers to temporary cessation of aqueous humor secretion due to ischemic damage to ciliary epithelium after an attack of acute PSC. Clinical features in this stage are similar to acute PSC, except that IOP is low and pain is markedly reduced. Subsequent recovery of ciliary function may lead to chronic elevation of IOP with cupping and visual field defects. Treatment include topical steroid drops to reduce inflammation, laser peripheral iridotomy to be performed. Trabeculotomy is required when IOP rises constantly. Vox triad, it may be seen in both treated and non-treated cases with after acute attack of PAC. It is characterized by glaucoma, flecken, anterior subcapsular lenticular opacity, patches of iris atrophy, slightly dilated, non-reacting pupil, etc. Primary angle closure glaucoma, it's a most important condition. can be considered analogous to term chronic primary angle glaucoma used in clinical situations. Pathogenesis it results from gradual cynical closure of angle of cynical closure. Untreated patient with PSC may over period convert to PSCG without history of subacute or acute of PSC. Clinical features PSCG may clinically manifest as subacute, acute or chronic PSCG. Subacute and acute PSCG clinical present similar to subacute and acute PSC respectively, except that glaucomatous optic disc changes and visual field defects are always present in PSCG in any condition, subacute or acute. Chronic PSCG intraocular pressure remains constantly elevated, eyeball remains white and painless, except in post acute angle closure is where eye may be congested and irritable. Optic disc show glaucomatous cupping. Visual field defects similar to POAG. Gonioscopy reveals more than 270-degree angle of closure along with peripheral anterior synechiae. The gonioscopy finding provide the only differentiating feature between POAG and chronic PSCG. Diagnosis. Defining criteria for primary angle closure glaucoma is iridotrabecular contact is noted on gonioscopy. Is greater than 270 degree of angle. PAs are formed. Synechiae. Peripheral anterior synechiae is formed. IOP is elevated. Optic disc show glaucomatous. Visual field defects in impression. Angle is abnormal in function and structure with optic neuropathy. Treatment. Laser iridotomy alone or along with medical treatment similar to POG should be treated first. Trabeculotomy is needed when the above treatment fails to control IOP. Prophylactic laser iridotomy in fellow eye must also be performed. Absolute primary angle closure glaucoma. Clinical feature painful blind eye. Eye is painful, irritable and completely blind. No light perception. Perilimbal reddish blue zone. A slight ciliary flush around the cornea due to dilated anterior ciliary veins. Perilimbal reddish blue zone. Caput medusae. A few prominent large vessels are seen in long-standing cases. Cornea is early in cases is clear but insensitive. Slowly it becomes hazy and may develop epithelial bullous keratopathy or filamentary keratitis. Anterior chamber is very shallow. Iris become atrophic. People become fixed and dilated and gives a greenish hue. Optic disc show glaucomatous optic neuropathy. Intraocular pressure is high. Eyeball becomes stony hard. Management of absolute glaucoma. Retrobulbar alcohol injection. It may given to reduce the pain. First xylocaine injected, then 1 ml of 80% alcohol is injected. Destruction of secretory ciliary epithelium to lower IOP may carried out by cyclocryotherapy or cyclodiathermy or cyclophotocoagulation, enucleation of eyeball. It may be considered when pain is not relieved by conservative. The frequency with which a painful blind eye with high IOP contains a malignant growth justifies its removal. Complications. If not treated, absolute glaucoma if not treated, following complication may occur due to prolonged high IOP: corneal ulceration, staphyloma formation, atrophic bulbi. Corneal ulceration results from prolonged epithelial edema, insensitivity. Staphyloma formation as a result of continued high IOP. Sclera becomes very thin and atrophy and ultimately bulges out either in ciliary region, ciliary staphyloma, or equatorial region, equatorial staphyloma, optic atrophic bulbi. Ultimately ciliary body degenerates, IOP falls and eyeball shrinks. Secondary glaucomas. It's not a disease only but a group of diseases in which rise of intraocular pressure associated with some primary ocular and systemic disease. Classification depending upon mechanism of rise in IOP. Secondary open angle glaucoma, in which aqueous outflow may be blocked by pre-trabecular membrane, trabecular clogging, edema and scarring, post-trabecular elevated episcleral venous pressure. Secondary angle closure glaucoma, which may or may not be associated with pupillary block. Depending upon cause to primary disease, secondary glaucoma are named as follows: lens-induced glaucoma, inflammatory glaucoma, pigmentary glaucoma, neovascular glaucoma, glaucoma associated with iridocorneal endothelial syndrome, pseudo-exfoliate glaucoma, glaucoma associated with intraocular hemorrhage, steroid-induced glaucoma, traumatic glaucoma, glaucoma infectia, glaucoma associated with intraocular tumors, phacomorphic glaucoma, note ciliary congestion, dilated pupil and intumescent senile cataractous lens. Lens-induced phacogenic glaucoma. Lens-induced secondary angle-closed glaucoma, phacomorphic glaucoma, phacotopic glaucoma. Phacomorphic is swollen lens, phacotopic is anti-lens displacement. Lens-induced secondary open-angle glaucoma, phacolytic lens party glaucoma, phacoanaphylatic glaucoma, etc. Phacomorphic glaucoma is an acute secondary angle-closed glaucoma. It is caused by intumescent lens, that is swollen cataractous lens due to rapid maturation of cataract, or sometime following traumatic rupture of capsule in main cause of phacomatic glaucoma. And anterior subluxation or dislocation of lens and spirophakia also cause of phacomorphic glaucoma. Pathogenesis: swollen lens pushes the iris forward and obliterates the angle, causing secondary angle-closed glaucoma. Further, the increased iridolenticular contact also causes potential pupillary block and iris bomb formation. Clinical presentation: phacomorphic glaucoma presents acute congestive glaucoma with features almost similar to acute primary angle-closed glaucoma, except that lens is always cataractous and swollen. Lens is cataractous. Demonstration of deep antechamber and open angle in fellow eye helps in differentiating from acute primary angle-closed glaucoma. Treatment: medical treatment to control IOP by IV mannitol, systemic acetazolamide, and topical beta blockers. Laser radiotherapy may be effective in breaking angle closure attack. Cataract extraction with implantation of PCIOL is the main treatment of phacomorphic glaucoma. Phacolytic glaucoma, lens protein glaucoma. It is a type of secondary open angle glaucoma in which trabecular muscle is clogged with lens proteins, macrophages, which phagocytes the lens protein and inflammatory debris. Leakage of lens protein occurs through intact capsule in hypermature cataract, Morgaginian cataract. Clinical features of acute congestion glaucoma due to rise in IOP in eye having hypermature cataract. Anterior chamber may be deep and aqueous, may contain fine white protein particles which settle down as pseudohypopyon. Anterior chamber angle is open on gonioscopy. Management consists of medical therapy to lower IOP and extraction of hypermature cataract. Lens particle glaucoma, it is secondary open angle glaucoma in which trabecular mesork is blocked by lens particle floating in the aqueous humor. It may occur due to lens particle left after accidental or planned extracapsular extraction due to following traumatic rupture of lens. Clinical symptoms of acute rise in IOP associated with lens particle in anterior chamber. Management: medical therapy to lower IOP, irrigation aspiration of lens. Phacoantigenic glaucoma, there occurs fulminating acute inflammatory reaction due to antigen antibody reaction. Lens protein mechanism is rise in IOP and its management similar to that of acute inflammatory glaucoma. Typical finding is a granulomatous inflammation in the involved eye after it undergoes surgical trauma. Pathogenesis: as in the case of lens particle glaucoma, there is usually preceding disruption of lens capsule by extracapsular extraction. Penetrating injury or leak of proteins from the capsule. Distinguishing feature of latent period during which sensitization of lens protein occur. IOP is then raised due to inflammatory reaction of uveal tissue excited by lens matter. Basically, it is also type of secondary open angle glaucoma and where trabecular muscle is blocked by both inflammatory and lens particle. Management: medical therapy to lower IOP, treatment of iridocyclitis with steroids, irrigation aspiration of lens matter from anterior chamber. Glaucoma due to uveitis. Due to iridocyclitis, there are two types: non-specific and specific. Non-specific inflammatory glaucoma based on mechanism of rise in IOP by inflammatory glaucoma may be open angle inflammatory glaucoma, angle closed inflammatory glaucoma. Open angle consists of two types: acute open angle inflammatory glaucoma, chronic open angle inflammatory glaucoma. The mechanism is acute open angle glaucoma occurs due to trabecular clogging by inflammatory cells exudate some turbid aqueous humor, and trabecular edema due to associated trabeculitis and postacral induced rise in IOP. Clinical feature: it is characterized by features of acute iridocyclitis associated with raised IOP with open angle of anterior chamber. IOP usually returns to normal after acute episode of inflammation. Management includes treatment of iridocyclitis and medical therapy to lower IOP by using hyperosmotic agents, acetazolamide, beta blockers, eye drops, timolol and betaxolol. Mechanism of rise in IOP includes chronic trabeculitis, trabecular scarring. Clinic features include rise in IOP, open angle, no active inflammation, but signs of previous episode of uveitis are often present. Some chronic cases may also have signs of glaucoma disc changes and field defects. Treatment consists of medical therapy, trabeculotomy, cyclodistractive procedures, cyclodiode. Angle closure inflammatory glaucoma. Mechanism of rise in IOP. Secondary angle closure with pupillary block. Pupillary block due to annulus synechiae or occlusio pupillae lead to iris bomb formation. Secondary angle closure without pupillary block occurs due to organism of inflammatory debris in the angle, which on contraction pulls the iris over trabeculum. It is followed by gradual and progressive synechial angle closure with the eventual elevation of IOP. Clinical feature include IOP, occlusia pupillae, iris bomb, etc. Management. Prophylaxis. Acute iridocyclitis should be treated energetically with local steroids, atropine, prevent formation of synechiae. Curative treatment. It consists of medical therapy to lower IOP. Surgical or laser iridotomy may be useful in pupil block with angle closure. Filtration surgery may be performed. Specific hypertensive uveitis syndrome, Fuchs uveitis, glaucomatocyclitic crisis, pigmentic glaucoma. It's a type of secondary open angle glaucoma. About wherein clogging of trabecular mesocarp occurs due to pigment particles. Pigment dispersion syndrome. It occurs due to pigment dispersion syndrome. Exact mechanism pigment shedding is not known. Perhaps pigment release is caused by mechanical rubbing of posterior pigment layer of iris with zonular fiber. Clinical feature: young myopic males. Characteristic glaucomatous features are similar to primary open angle glaucoma. Deposition of pigment granules in the anterior segment structures such as iris, posterior surface of cornea, Krukenberg spindle, trabecular mesocarp, ciliary zonules, and crystalline line. Gonioscopy shows pigment accumulation along the Schwalbe line, especially inferiorly. Iris transillumination shows radial slit-like transillumination defects in mild periphery. Treatment: it is exactly on the lines of primary open angle glaucoma. Neovascular glaucoma: it is an intractable glaucoma which results due to formation of neovascular membrane involving the angle of anterior chamber. Etiology: neovascularization develops following retinal ischemia, which is common feature of proliferative diabetic retinopathy. Central retinal vein occlusion, sickle cell retinopathy, Eales disease. Other rare causes are chronic intraocular inflammation, intraocular tumors, long-standing retinal detachment, central retinal artery occlusion. Clinical profile: pre-glaucomatous stages, open angle glaucoma, secondary angle closure glaucoma. Treatment of NVG: pan-retinal photocoagulation, medical therapy and conventional filtration surgery. Glaucoma drainage service. Glaucomas with intraocular tumors, malignant melanoma, and retinoplasm may occur one or more by following mechanisms: trabecular block due to clogging by tumor cells, neovascularization of angle, venous stasis following obstruction of vortex veins, angle closure due to forward displacement of iris diaphragm by increasing tumor mass. Treatment: enucleation of eyeball should be carried out as early as possible so that stop the spread of cancer. Pseudo exfoliation glaucoma is characterized by deposition of amorphous grey dandruff-like material on the pupillary border, anterior lens surface, posterior surface of iris, zonules, and ciliary pus. Exact source of exfoliate material is still not known. Secondary open angle glaucoma is associated about 50% of cases. Exact mechanism of rise in IOP is not clear. Trabecular blockage by exfoliate material is considered as probable cause. Clinically, the glaucoma behaves like POAG and it thus managed on same lines. Glaucomas in aphakia, pseudophakia. It is the term used to replace the old term aphakic glaucoma. It implies associated glaucoma with aphakia and pseudophakia. It includes following condition: raised IOP with deep anterior chamber in early post-operative period. It may be due to hypemia, inflammation, retained cortical matter, or vitreous filling the anterior chamber. Secondary angle closure glaucoma due to flat anterior chamber. Secondary angle closure glaucoma due to pupil block. Undiagnosed pre-existing primary open angle glaucoma. Steroid induced glaucoma It may develop due to development patients operated for cataract due to post-operative treatment with steroids. Epithelial ingrowth may cause intractable glaucoma in post-operative period. Steroid-induced glaucoma. It has been postulated that response of IOPs to steroid genetically determined. Roughly 5% of general population is high steroid responder. 35% of moderate and 60% non-responder. In high responder, rise of IOP after 6 weeks of steroid therapy is marked. Mechanism is responsible for IOP increase is unknown, and obstruction is also unknown. Glycosaminoglycans theory. Corticosteroids inhibit release of hydrolysis, stabilizing lysosomal membrane. Consequently, the gags present in the trabecular measure cannot depolymerize and they retain water. This leads to narrowing trabecular spaces and decrease in aqueous flow. This is open angle glaucoma. Endothelial cell theory. Under normal circumstances, endothelial cells lining the trabecular measure act as phagocytes and phagocytose the debris from aqueous humor. Corticosteroids are known to suppress phagocytic activity of endothelial cells, leading to collection of debris in the trabecular measure and decrease the aqueous flow. Prostaglandin theory. Prostaglandin E and F are known to increase the aqueous outflow facility. Corticosteroids can inhibit the synthesis of VG and PGF, leading to decrease in aqueous outflow. Clinical features. Steroid-induced glaucoma typically resembles POAG, open angle glaucoma. It usually develops following weeks of topical therapy with strong steroids and months of weak steroids. Management can be prevented by judicious use of steroids, regular monitoring of IOP. Treatment consists of discontinuation of steroids, medical therapy with 0.5% timolol maleate, filtration surgery. Traumatic glaucoma mechanism. Inflammatory glaucoma due to idiopathic glaucoma due to intraocular hemorrhage. Lens induced glaucoma due to ruptured, swollen or dislocated lens. Angle closure due to peripheral anterior synechiae formation following perforated corneal injury producing adherent glaucoma. Epithelial fibrous ingrowth. Angle recession glaucoma. Angle recession refers to rupturing ciliary body face. Unilateral open angle glaucoma usually occurs after years of blunt trauma. Angle recession is not the cause of glaucoma but just indicator of old trauma. Glaucoma occurs due to slowly induced fibrosis of trabecular measure. Management. Medical therapy with topical 0.5% timolol, oral lestrozolame. Treatment of associated causative mechanism. Surgical intervention also can be done. Ciliary block glaucoma. It is a rare condition which may occur as complication of any intraocular operation. It classically occurs in patients with primary angle closure glaucoma operated for peripheral iridectomy or filtration trabeculotomy surgery. It is characterized by markedly raised IOP as with shallow or absent anterior chamber. Mechanism raised in IOP. It is believed that rarely following intraocular operation, the tips of ciliary process rotate forward and press against the equator of lens in phakic eyes or against the intraocular lens in pseudophakic eyes, against the anterior highlight face or vitreous in aphakic eye, and thus block the forward flow of aqueous humor, which is diverted posterior and collects as aqueous pockets in vitreous. As a consequence of this, the iris lens diaphragm is pushed forward, IOP is raised, and anterior chamber becomes flat. Clinical feature. Patient develops severe pain, blurring of vision following any intraocular operation. On examination, the main features are persistent flat anterior chamber, marked raised IOP, negative CDL test, unresponsive or even aggravation by myotics, malignant glaucoma by phakic, aphakic and pseudophakic. Management include medical therapy consists of 1% atropine drops, ointment or dilate ciliary ring, break the ciliolenticular ciliovitreal contract, acetazolamide 250 mg Q80, 0.5% timolol maleate to decrease aqueous protection, and intravenous menthol to cause detergence of vitreous gel. YAG laser and be undertaken in aphakic and pseudophakic patient if the condition does not respond to medical therapy in 4 to 5 days. Surgical therapy is in the form of pars plana vitrectomy with or without lensectomy. Glaucoma associated with intraocular hemorrhage, red cell glaucoma, hemolytic glaucoma, ghost cell glaucoma. It is associated with fresh traumatic hypemia. It is an acute secondary open angle due to obstruction of trabecular measure caused by macrophages laden with raised RBC. Anterior chamber full of blood, that is red cell glaucoma. Ghost cell glaucoma is a type of secondary open angle glaucoma which occurs in aphakic or pseudophakic eyes with vitreous hemorrhage. After about 2 weeks of hemorrhage, the RBCs regenerate and lose their pliability and become khaki colored cells, ghost cells, which pass from vitreous into anterior chamber and block the pores of trabecular, leading to rise in IOP. Hemocytosis is a very Hemostatic glaucoma, rare variety of glaucoma occurring due to sclerotic change in trabecular muscle caused by iron from phagocyte hemoglobin endothelial cells of trabeculum. Glaucomas with endocorneal endothelial syndromes. Treatment is usually frustrating medical treatment, trabeculotomy, glaucoma drainage device, surgical procedure, glaucoma, peripheral iridectomy, indication, treatment of all stages of primary angle-closure glaucoma, prophylaxis of LOI, surgical technique, incision, 4 mm limbal or preferably corneal incision made with help of razor blade fragment. Iris prolapse. The posterior lip of iris is depressed so that iris prolapse. If the iris does not prolapse, it is grasped at the peripheral with the iris forceps. Iridectomy. A small full thickness piece of iris is excised by Devaker scissor. Reposition of iris. Iris reposited back into anterior chamber by stroking the lips of the wound or with iris repositor. Wound closure is done with 1 or 2 10-0 nylon switches with bury knots. Subconjunctival injection of dexamethasone, gentamicin. Patching of eye is done with sterile iPad. Goniotomy, trabeculotomy, filtering operations, external filtration surgery, free filtering operations, full thickness fistula. These are no longer preferred because of high rate of post-operative complication. Their names are mentioned only for historical interest. Gordon filtering surgery, non-penetrating filtration surgery, internal filtration surgery, and external filtration surgery. Trabeculotomy. A is fornix based conjunctival flap. B and C partial thickness of scleral flap and excision of trabecular tissue. D is peripheral iridectomy and closure of flap. E is closure of flap. Mechanism. Indication: primary angle glaucoma with peripheral anterior synechiae involved more than 270 degree or where PA and medical treatment fail. Primary open angle glaucoma not controlled with medical treatment. Congenital development glaucoma, secondary glaucoma. Mechanism: filtration. New channel fistula is created around the margin of scleral flap through which aqueous flows from anterior chamber into subconjunctival space. If the tissue is dissected posterior to scleral space, cyclodialysis may be produced, leading to increased UV scleral outflow. When trabeculotomy was introduced, it was thought that aqueous flows through curtains of Schlemm's canal. However, now it is established that the mechanism has negligible role. Surgical technique: initial steps of anesthesia, cleansing, draping, exposure of eyeball, fixation of superior rectus suture are similar to cataract operation. Conjunctival flap. Fornix based or limbal based conjunctival flap is fashion and underlying sclera is exposed. The Tenon's capsule is cleared away using 2K knife and hemostasis achieved by cautery. Scleral flap. Partial thickness limbal base scleral flap 5 mm size is reflected towards the cornea. Excision of trabecular tissue. Narrow strip 4 mm 2 mm of exposed deeper sclera near the cornea containing canal of Schlemm. Trabecular mesork is excised. Peripheral iridectomy is performed at 12 o'clock position with Devaker scissor. Closer. Scleral flap is replaced and 10-0 nylon switches are applied. Then conjunctival flap is reposted and sutured with 2 interrupter sutures in case of fornix based flap or continuous suture in limbal based flap. Subconjunctival injection of dexamethasone, gentamicin are given. Patching are done. Complication: few complications are shallow anterior chamber hypema, iritis, cataract due to an accidental injury to lens, and etc. Use of anti-metabolites with trabeculotomy. When following risk factors are present: previous failed filtration surgery, glaucoma in aphakia, certain secondary glaucoma, inflammatory glaucoma, post-traumatic angular resistance glaucoma, and patients treated with topical anti-glaucoma medications, particularly symptomatic for 3 years. Over 3 years, chronic cicatrizing conjunctival inflammation. Then anti-metabolite agents, 5-fluorouracil metomycin can be used. Metomycin is only used at the time of surgery. Spawn sodium 0.02% solution of metomycin is placed at site of infiltration between scleral and tenon's capsule for 2 minutes. Use of collagen implant with glaucoma filtration surgery. Technique: usually 6 mm diameter, 1 mm thick implant is sutured over scleral flap. Initial step: conjunctival flap, sutureless trabeculotomy. Initial step: conjunctival flap fashioning is similar to conventional trabeculotomy. Sclerocorneal valvular tunnel 4 mm 4 mm is made by first making 4 mm partial thickness scleral groove about 2.5 mm away from superior limbus with help of razor blade fragment. A 4 mm wide sclerocorneal tunnel which extends about 1.5 mm in the clear cornea is then made with the help of crescent knife. Entry into antechamber is made with help of sharp 3.2 mm angle keratome. Punching of posterior lip of antechamber entry side is then performed with help of Kelly's punch to make a sclerostomy of about 2 mm 2 mm size. Peripheral iodectomy is performed at 12 o'clock position with help of Devicker or Vanna scissor. Closer antechamber filled with balanced salt solution or air to close the valvular sclerocorneal internal incision. Conjunctival flap is reposted anchored with wet filled cautery. Non-penetrating filtration surgery. 2 currently used procedures are deep sclerotomy. In this procedure, after making partial thickness scleral flap, second deep partial thickness scleral flap is fashioned excised, leaving behind thin membrane consisting of very thin sclera, trabeculum, decimate membrane through which aqueous diffuses out. The superficial scleral flap is loosely approximated and conjunctival incision is closed. Viscocanalostomy. Internal filtration surgeries: canaloplasty, trabectome, eye stent. Glaucoma drainage device commonly used are Moltena, Krupin, Denver, Ahmed, glaucoma valve. Indication: neovascular glaucoma, glaucoma with aniridia. Intractable cases of primary and secondary glaucoma where even trabeculotomy with adjunct antimetabolite therapy fails. Express glaucoma implant. Mini shunt is small stainless steel device which is now implanted under the partial thickness scleral flap as a modification of trabeculotomy. It provides a more favorably safety and post-operative recovery profile. Cyclodestructive procedures. Indication: these procedures are used mainly in absolute glaucoma. Cyclocryotherapy, YAG laser cyclodissection, diode laser cyclophotocoagulation. Anesthesia: topical and peribulbar block anesthesia given. Lid separation done with eye speculum. Cryo applications: cryo is applied with a retinal probe placed 3 mm from limbus. Freezing at 80 minus 80 degree. Mechanism: IOP is lower due to discussion of secretory ciliary epithelium. The cells are destroyed by intracellular freezing. Site of cyclocryopexy: artificial drainage shunt operation using Molteno implant.